Okay, for our next presentation, we're going to talk about the use of evidence to guide clinical practice in neonatal nutrition. You've seen a lot today already about published scientific reports that show certain things, and indirectly, Professor Hay and the rest of us have told you how we base our treatment recommendations on these published experimental results. But I'm going to try to present a more general approach to thinking about this issue. How do we use the evidence that's available to us to guide clinical practice in neonatal nutrition? When should we take new research and apply it to our practice? So how do we evaluate published research and apply the findings to our nutritional practices? We need to apply the best available evidence gained from the scientific method to clinical decision-making, and we must assess the strength of evidence for the risks and benefits of a treatment or lack of treatment. Dave Sackett said, "Evidence-based medicine is the integration of best research evidence with clinical expertise and patient values." And so you have the intersection of the best research evidence, clinical expertise, and patient concerns. And right here in the middle is where we would like our practices to lie. There are a number of different types of publications, and when you read them, you should be able to classify them, first of all, and understand the hierarchy of clinical evidence. A single case report doesn't help very much. This is the weakest evidence, but sometimes gives us ideas for doing additional research. A case series is a little better. A case control study is the next best because you have a comparison group at least. A cohort analytic study I'll explain in a minute, but that's the next highest level. And then we come to experimental studies, the best of which are randomized controlled trials. And finally, the highest level of evidence is a systematic review or of randomized controlled trials, such as those that you can see with the Cochrane reviews. So these are the strongest. The cohort study is a prospective study in which you have an exposed cohort of patients and an unexposed cohort of patients, and you follow these patients prospectively and see how many in each group have an outcome of interest. There are lots of examples of this, but you could say, for example, what's the impact of iodine-containing solutions on the umbilical cord at birth to subsequent hypothyroidism. You would take the babies with cords who were treated one way, maybe in a different hospital or the same hospital, another group of patients, and then keep track of them and see what the outcome is. The opposite design is a case control study. This is a retrospective study in which you take patients with an outcome of interest and patients without this outcome and go back and review their previous history and their medical records and see whether patients in this group had a higher rate of exposure to something than the ones in the other group. So either way, you're ending up with a 2x2 table and the same sort of statistical approach. It could be a chi-squared or Fisher exact, but the difference is that the case control study is retrospective, the cohort study is prospective. In general, the cohort study is going to be a more powerful design because it is prospective, but it's not practical in certain situations where the outcome is extremely rare. That's where the case control study is sometimes the best one that we can do if we have outcomes that are exceedingly rare, like a rare form of cancer or something like this. The most powerful research design minimizes the risk of impact from confounding variables, both known and unknown, reduces the risk of bias, and should be used whenever possible. That's the randomized clinical trial. This is not always possible, however. For example, if you wanted to compare breastfeeding versus formula feeding, it wouldn't be acceptable to ask mothers to subject themselves to a coin flip as to whether they were going to breastfeed or formula feed, because they have their own ideas, of course, and have already decided ahead of time which they're going to do. And in fact, we know that breastfeeding is superior. So with an outcome like that, it's not generally possible to do a randomized clinical trial. However, you could do a randomized clinical trial for what are you going to supplement mother's milk with if the mother's milk is inadequate. You could then randomize those babies between formula as the supplementary feeding source and breast milk from a milk bank, for example. Well, this is a guy that jumped out of an airplane. And what does the evidence say about his chance of survival? There was, in fact, a paper published in the British Medical Journal in 2003 that it was entitled "Parachute Used to Prevent Death and Major Trauma Related to Gravitational Challenge: A Systematic Review of Randomized Controlled Trials." So this is obviously a little bit of a facetious paper, but it's indirectly making a comment about the use of systematic reviews. The authors concluded, as with many interventions intended to prevent ill health, the effectiveness of parachutes has not been subjected to rigorous evaluation by using randomized controlled trials. Advocates of evidence-based medicine have criticized the adoption of interventions evaluated by using only observational data. We think that everyone might benefit if the most radical protagonists of evidence-based medicine organized and participated in a double-blind, randomized, placebo-controlled crossover trial of the parachute. So obviously they're making the point that we don't always have this level of evidence when we make decisions about managing our patients. And we can't withhold making decisions. We can't withhold providing treatment, but we have to use the best evidence that's available or try to go and get better evidence. Okay, let's take an example. A 900-gram, 27-week baby boy. This could be the same 27-week baby that you heard about earlier today. Intubated in the delivery room, given surfactant at 1 hour. At 4 hours, requires 50% oxygen and a mean airway pressure of 8. The pH is 7.29, PCO2 55, and arterial PO2 is 60. What is his probability of survival? Okay, this is going to vary from place to place. You should know approximately what it is in your own hospital. But the question here is, if he survives, what is his risk of bronchopulmonary dysplasia? And this we'd also like to know. And is there anything we can do to reduce that risk? Anybody have any ideas? What are the things that we can do to reduce the risk of BPD for this patient? Minimal ventilation. Early extubation. Okay. Anything else? Restrict the fluids, avoid the PDA, or take care of it. Yeah. Feeding. This is a nutrition conference, right? So probably something related to nutrition. How about steroids? Will a short course of dexamethasone reduce the risk of bronchopulmonary dysplasia? Yes. Yes, but. After the second. Okay, what about the first week? Yeah, does it work? Yeah, it works. Okay. Okay, you guys are pretty smart. Here's the Cochrane review on the use of early dexamethasone for prevention of bronchopulmonary dysplasia, and this is patients of 1 week of age or less, and you can see that there are a number of trials, and the overall result is that the relative risk is 0.7, which means you can reduce the risk of VPD by 30% by giving dexamethasone in the first week of life. However, here are other outcomes from a similar systematic review of early steroids. And up here you see there are some benefits. You reduce the risk of BPD and death or BPD using either of two definitions, oxygen at 28 days postnatal age or at 36 weeks postmenstrual age. It reduces the risk of still being intubated at day 7. It reduces the need for late steroids. It reduces PDA, reduces severe ROP. However, it has some bad effects. It increases hyperglycemia, hypertension, GI perforation, GI bleeding, and cerebral palsy, and the combined outcome of death or cerebral palsy. So any bad effects that involve the brain are things we should take very seriously. And so this is the dilemma. We have a drug that can reduce the risk of BPD, get the baby off the ventilator faster, reduce the risk of PDA, but the price we pay is a higher risk of brain problems. Here's another illustration of this. You see the risk of chronic lung disease is significantly decreased, but the risk of intestinal perforation and cerebral palsy are increased. So this is typical of treatments that neonatologists have to provide to their patients. There are often benefits and risks, and we have to weigh these in making decisions. How about high-frequency ventilation? How many of you have high-frequency ventilation available? Does this reduce the risk of BPD? No. Okay. Well, the Cochrane review says that it does. You see the risk difference is 0.06, and this doesn't cross the line of unity, so it is a statistically significant reduction. However, there is a increase in the risk of grade 3 or grade 4 intraventricular hemorrhage, which is not something we want to deal with if we can avoid it. There's a lot of discussion about whether this is a real phenomenon, the increased risk of intraventricular hemorrhage. It's been seen mainly in one of the early trials of high-frequency ventilation, and proponents of high-frequency ventilation claim that the technique wasn't applied correctly and that there was resistance to venous return from the brain probably, and that's probably what happened. But nevertheless, if you look at the evidence in this form as a systematic review and meta-analysis, it would tell you that maybe high-frequency ventilation does reduce BPD, but there might be a bad side to this story too. Okay, we mentioned earlier today that vitamin A seems to reduce the risk of BPD. I showed you the study of Tyson from the New England Journal in 1999. There's also a Cochrane review that comes to the same conclusion, that vitamin A in a dose of 5,000 international units 3 times a week will reduce the risk of bronchopulmonary dysplasia. And so the question comes up, why aren't we all doing it? And this is a question that we've talked about a lot in the U.S. It's a treatment that seems to have very little risk. It's not very expensive, but it does reduce the risk of bronchopulmonary dysplasia The relative risk is 0.85. So even though you can't prevent most cases, you can prevent some cases. Yet it's not been universally adopted in the U.S. where these studies were done. Caffeine? Yeah, caffeine will reduce the risk of bronchopulmonary dysplasia. The CAP trial that was published by Barbara Schmidt in the New England Journal of Medicine that's reduces the risk of bronchopulmonary dysplasia and also reduces the risk of bad neurodevelopmental outcome. How many of you are using caffeine? Okay. Good. I forgot to make a slide for that, but I'll put it in the next time. Okay, let's talk about some of the measurements of treatment effect that you will read about in the Cochrane reviews and in other publications. If we look at this as patients who are treated or control patients, and those who have the event of interest and those who have no event, we can divide this 2x2 table and label these cells A, B, C, and D. The relative risk is A over A plus B divided by C over C plus D. And that sounds like a complicated mathematical formula, but it's pretty intuitive. And that's, what's the risk of the event in this group divided by the risk of the event in the control group. And the relative risk difference is 1 minus this number. The odds ratio, which you will also see used, is a little bit like the relative risk, but it's a simpler derivation. It's A times D divided by B times C. And this is used in certain situations, for example, where the incidence in the control population may not be as well defined. I may not be saying that exactly right, but I always have to ask my statistician which one I should be using. In general, if you can, I think it's better to use relative risk. The absolute risk difference is the risk in the treatment group minus the risk in the control group. And the number needed to treat is 1 divided by this number. And so that's how many patients do we have to treat with this treatment in order to prevent one of these bad events. And here we are with the actual numbers from the vitamin A Cochrane review. If you put together the studies of vitamin A and BPD, there were a total of 363 babies who got vitamin A and 361 who got control. And here's the number in each of those groups that got BPD. And so the relative risk is 167 divided by 363 over 198 divided by 361. And so the relative risk is 0.839. Another way to say that is that there is about a 16.1% reduction in the risk of BPD. The relative risk difference is 1 minus this, or 0.161. The odds ratio is this times this divided by this times this, and it's 0.701. The absolute risk difference is this number minus this number, and so it's 0.088, and the number needed to treat is 1 divided by this, or 11.4. So that means if you give vitamin A to 12 babies, you'll prevent 1 case of bronchopulmonary dysplasia. So when we think about other treatments that we have put into practice, there's lots of things we do where the number needed to treat was larger than this. This is a pretty good number needed to treat. Even though the relative risk is not as low as we would like, the number needed to treat is pretty low, which means if it's a safe treatment and an affordable treatment, we probably should do it. Now, the number needed to treat also has to be compared with another number, which is the number needed to harm. And that's if there's a harmful side effect of this treatment, how many patients do you have to treat in order to see one harmful outcome? So in the case of early steroids, you have both number needed to treat to prevent BPD and a number needed to harm to cause a case of cerebral palsy or a case of GI perforation. So you take those numbers and you compare them and weigh them, and so this is kind of how we approach this. We may have different values on the good outcome and the bad outcome too. We may say, I don't care what the calculation is, cerebral palsy to me is an unacceptable outcome, and I'm not going to do anything that's going to contribute to that, and even if my patient is going to die from lung disease. So there are lots of other aspects that you can't put into a mathematical formula. Okay, here's antenatal steroids for prevention of RDS. This is something that's been accepted and is practiced around the world. And this is to show you how the number needed to treat can change with baseline risk. So if we have a baby of 28 weeks or less, there's an 80% risk of RDS. So in that case, we only have to treat 3 babies to prevent 1 case of RDS. But if we get down here to 34 weeks, there's only a 20% baseline risk of RDS. And so we're going to have to treat a lot more patients. So at 28 weeks and less, the number needed to treat is 3. At 34 weeks, the number needed to treat is 12. So we may take this into account, and so the baseline risk is one of the things that will influence this number needed to treat and our decision about whether to provide it. As you know, the recommendations of the obstetrical groups are that antenatal steroids should be given for any baby that might be delivered before 34 weeks. So somebody's made the decision that if the number needed to treat is above 12, we're not going to give them other antenatal steroids. And now, another way to look at this is the threshold number needed to treat. This is the break-even point. And I think this is 34 weeks for antenatal steroids. But this is the point at which the clinician judges the negative aspects of treatment to equal the therapeutic benefit. So the threshold number needed to treat for antenatal steroids is 12. And the minimum event rate for treatment is 20%. And this happens to fall at gestational age of 34 weeks. Now, for most treatments, you're not going to necessarily have a pretty curve like this that you can go and look at. The data may or may not be there, but if it's a treatment that's been used pretty widely and studied widely, and you have data by baseline risk group, then you can perhaps do this. In the case of surfactant, there should be plenty of data available to say what's the threshold number needed to treat and what's the minimum event rate for treatment. So when faced with a decision about whether to give your patient a certain treatment, the strongest evidence of efficacy and safety comes from the Cochrane database. And I hope all of you know that this is available for everybody in the world at no cost. You don't have to subscribe. You don't have to pay anything. And this is the website where you can find all of the Cochrane reviews in neonatology. Now, this may not be, this is, as far as I know, it's not true for other specialties. So we're very lucky in neonatology that we have these reviews are all available on the National Institutes of Health website. Okay, did somebody get it written down? Okay, as long as one person did, we're okay, we can go on. So when we bring research findings to practice, we don't want to do it too soon and we don't want to do it too late. neonatologists have sometimes harmed their patients by introducing new therapies too quickly without sufficient evidence of safety and efficacy. And this article by Robertson gave a nice list of some of these mistakes that have been made by neonatologists. And here you can see them in the hands-off years in the early 20th century, the heroic years during the mid-20th century, and the experienced years, which is late 20th century. You can see all of these harms that we've caused to our patients by doing things that we thought were going to be beneficial. And I think this list is still growing and will continue to grow. One of our responsibilities is to try to slow this down and make sure that the treatments we're applying have been carefully looked at and are beneficial and safe. There are other cases where new therapies with well-established safety and efficacy have not been widely accepted, such as vitamin A for prevention of chronic lung disease and antenatal glucocorticoids for prevention of RDS and death. We've known since 1972 that antenatal corticoids are beneficial in protecting the preterm infant, but they were not widely adopted until 25 years later. Here you can see all of the studies that were published over the years, starting with the study by Liggins in 1972, which showed benefit. Over the years, there have been many more studies. Some showed benefit, some did not. This is the overall view with more than 3,000 patients studied, shows a very striking benefit. This is a meta-analysis. Now, there's another way to look at these data with a different type of approach, which is called a cumulative meta-analysis, which Professor Sinclair developed. And what that means is, let's pretend that every time a new study was published, we did a meta-analysis like this of the studies that were published so far. When would we have seen that this was, in fact, a good treatment? And here you can see each additional study has narrowed this level of confidence, but basically we've got the same magnitude of effect, and even the very first study in 1972 hit the nail right on the head and had the correct result, and everything after that for the next 25 years just provided additional support and confidence. Practice, however, did not change in the United States until the National Institutes of Health of the government called together a conference like this of experts where the data were reviewed, and the participants in the conference were asked to present a summary recommendation, and the recommendation was that antenatal corticosteroids should be used for preterm labor where the delivery might occur between 24 and 34 weeks. We now know that they're beneficial even before 24 weeks, but there's still obstetricians that won't give the antenatal steroids before 24 weeks. So know the evidence, base your practice on the evidence. If evidence is lacking, help get it. And when the evidence is sufficient, act on it. The team is not just you or me. It's the director of the unit, the other physicians, the nursing leaders, and the nutritionist. They should review the evidence together. We do this in the form of a monthly meeting in the evening in somebody's home where we have beer or wine or coffee, and we review several papers that may be new papers on a related topic, and try to decide as a group how we should apply this to our practice. We also can consult experts. You've seen our email addresses. If you don't believe us, we'll give you some other email addresses for other experts. Decide which practices hold the best promise of improving outcomes, and identify the outcomes that can be monitored to evaluate for improvement. There are other terms you might hear that are related to this evidence-based practice, and these are quality improvement, best practices, quality collaborative, and benchmarking. So these are other approaches to trying to improve outcomes that don't involve randomized clinical trials, but where people just gather data and make a change and see whether their results improve. So this is none of the study designs that I mentioned in that hierarchy, but it's still widely practiced. How can you compare your outcomes with those of other units? The Vermont-Oxford Network is a worldwide consortium of neonatal units that allow you to compare your outcomes with those of other places. Or you can start your own network or collaborative. In the US now, there are 4 or 5 states that have state-based collaboratives. One of the things that collaboratives have demonstrated can be done quite effectively is to reduce the rate of catheter-related bloodstream infections. This can be done very nicely. You don't have to do any more randomized clinical trials. Excuse me, the data are already there, and you just have to implement them in a systematic way. Now, one of the earlier presenters showed you this as an example of extrauterine growth restriction. This was taken from our neonatal unit in the 1990s, but with some implementation in standardization of nutritional support and some efforts at better practice, we were able to improve the growth of our babies. You can see it's still not equal to the fetus, but this is an example of a quality improvement project and some of the effect it can have. I'm going to end with just a few resources that are available to you for free on the internet. This is an evidence-based practice tutorial that you can go through step by step to learn about this. This one, I think, is provided by the University of Minnesota. I can give you these later if you didn't get them. And here's some other web-based resources that provide useful information about evidence-based medicine and clinical epidemiology. I'll just leave that one up there, or I'll come back to it. And lastly, this is a very, very good site for information. The Center for Evidence-Based Medicine at Oxford. They have free software tools and PowerPoint presentations and a classification system for levels of evidence that you should all know about. Thank you. First question.
Could you tell us about benchmarking?
Benchmarking, it means seeing your own results compared to results of others. And the Vermont-Oxford Network, for example, once a year, they send a report that shows how you compare to the whole network in terms of very low birth weight survival, risk of ROP, risk of necrotizing enterocolitis, risk of intraventricular hemorrhage. So you can kind of look at how you compare to the whole network. You can pick out hospitals of certain types. The hospitals are grouped, so you can pick out hospitals that you think are similar to yours and look at how you compare. They don't show you the exact results of other hospitals, but they will show you how you fall if you're in the bottom quartile or the middle or the top quartile. And I think it's quite useful in identifying areas where you might want to focus more effort. If you find that you're better than average in most things, but there's one area where your outcomes are worse, it might help you think about solutions. Questions, comments? Okay, thank you.